Before I start talking about Chapter 19, I want to talk in general about palliative and hospice care. It's been a long time coming. It's been a long road to get to this point because doctors and nurses, they like to fix their patients. They like to make them better. But at some point, we have to realize that we're not going to. Death and dying is part of the experience. And now there's specialties in palliative and hospice care for doctors and nurses so that we can make the end-of-life experience much better. If you'll walk with me here on page 320, we're going to talk about loss and grief. So loss is defined as a real or potential absence of someone or something of value. Grief is the normal personal response to a loss. And there's two types of grief. There's uncomplicated grief, which is helpful in accepting the reality of death. It's a very healthy response. It's important to remember that it's healthy. Complicated grief is prolonged, unresolved. It could be affected by some past experience that the patient or the family member has experienced and maybe not dealt with. Mourning is an outward part of coping with grief, and there's many different types of mourning, as we're going to find out when we get into culture. So the grieving process. The grieving process can be affected by culture, spirituality, families' experiences, their stages of development. Religious teachings usually include beliefs about death and life after death. Now there's many different religions, so we have many different beliefs about what happens after death. And also family members, past experiences and stages of development influence their responses to death and dying. The age of or stage of development also affects a person's reactions to death and dying. So children have a different understanding of loss and death than adults do, and we're going to talk about that on the next page. So in 1968, Dr. Kubler-Ross developed 5 stages. She wrote a book, Death and Dying, where she plotted out 5 stages of grieving. It's important for us to understand that denial is a big one. It's a refusal to acknowledge the terminal diagnosis. Just nope, don't have it, not going to happen. It's a defense mechanism that helps the patient and others to manage anxiety evoked by the threat of death. And then there's anger, and that's they can express anger towards themselves for getting themselves into this position. Maybe they ate wrong. They can look back and say, oh, I ate the wrong foods, I did the wrong things. And they can then express anger towards their loved ones, towards the healthcare workers, but don't take it personally. It's just a way of dealing with grief. Then there's bargaining. Now, bargaining is important. In this stage, the person recognizes the terminal nature of the disease and seeks to buy more time. So the loss is a punishment for past actions. And so the patient tries to negotiate with a higher power to gain more time. They try to buy more time by maybe making amends for something they've done in the past. So they bargain. If I do this, then maybe I can have more time with my loved ones. Then there's depression. Depression is an emotion, includes sadness, regret, and fear. Then there's acceptance. The individual somewhat emotionally detached and objective. The patient defines the loss as inevitable and then tries to make plans about their death. And some people do that. They plan their death ahead of time. So then there's age-related beliefs about death. So if we go to table 19.1, which is on page 322. Let's look at that, and I'm going to go to the next slide because I actually copied it from your book. So, age-related beliefs about death. In infancy to 5 years, the child has little or no understanding of death. They believe death is temporarily, like sleep. 6 to 9 years old, the child believes death is final, and one's own death can be avoided. Now, child believes death is related to violence, and we see so much of that now. Some children are surrounded by violence. And they also believe that wishing or hoping for death can make it happen. Then, when we get to the pre-adolescent age, 10 to 12 years old, it's important for us to understand about pre-adolescence. They believe death is an inevitable end to life. A pre-adolescent grasps his or her own mortality by discussing fear of death or life after death. They usually express feelings of death based on adult attitudes. They don't have any other point of reference. So their feelings of death is based on an adult's attitudes. It's important to remember that. And the 13 to 18-year-olds, or the adolescents, the adolescent may act out defiance of death through dangerous or self-destructive acts. Maybe they drive a fast motorcycle, just defying death. I can drive fast, nothing's going to happen to me. So it's important to understand that they might do dangerous or self-destructive acts at this age. And this is a very vulnerable age in adolescent. Then in young adulthood, their cultural and religious beliefs influence their attitudes about death, and they realize that death is a part of life. 45 to 65, they accept their own mortality as inevitable, and the middle-aged adult faces the death of parents and peers. 65 years and older, the older adult is afraid of prolonged health problems. They don't want to die alone. They don't want to have their long death experience where they suffer. So that's why hospice and palliative care is so great. So we'll go to the next and talk about awareness. So awareness on page 323. Awareness of terminal illness and impending death affects the dying person and the family both emotionally and physiologically. So notice I have Strauss and Glaser. So they talked about awareness in 1970. And they identified 3 states of awareness: closed awareness, mutual pretense, and open awareness. So closed awareness is the family and the patient recognizes that the patient is ill. Mutual pretense, they know of the terminal prognosis, but no one discusses it. And they actually avoid the subject. Open awareness, the patient and others involved freely discuss impending death. And this is when they can make plans. So palliative care, what is palliative care? Well, the word palliate comes from pallium, the Latin word for cloak. And to palliate is to cloak or cover up the symptoms of an illness without curing it. So the goal is to improve the quality of life for patients and their families by anticipating, preventing, and treating suffering. So they treat their physical symptoms, emotional, and physical support. So they focus on allowing natural death in a pain and symptom-controlled environment with psychosocial support. So usually there's a palliative care team that works to provide care and coordinate services for the patient and the family. So it's providing comfort, making the patient comfortable. Hospice focuses on quality of life, comfort, and dignity near the end of life. So palliative care is making the patient comfortable, knowing that maybe there's an illness that won't be cured, but they can be comfortable. But with hospice, they've realized that they've come to the end, and they want to be comfortable there too. So this includes bereavement care for survivors after the death of the patient. So now we're turning on to page 324. So there's some legal and ethical issues that pop up now. Because hospice, you have to be accepted into it by Medicare. So there's criteria for eligibility for meeting Medicare's criteria for hospice. And if you'll notice on page 324, it says management of pain and symptoms, assistance with emotional, psychosocial, spiritual aspects of dying. So those are the services, but look at the criteria. The criteria is the physician certifies that the patient has a life-limiting condition and that his or her life expectancy is 6 months or less. Now, if 6 months comes along and they haven't passed away, it can be renewed. So it can keep being renewed until the actual death of the patient. Now there's some legal and ethical issues. So organ donation. On your driver's license, you can mark, are you an organ donor? Now this doesn't mean that they're going to leave you if you're in an accident. They're going to look at your wallet and say, oh, you're an organ donor. I'm just going to leave you here and let you die. No, that doesn't happen. Those are older ways of thinking because that doesn't happen anymore. The decision to donate organs after death may be made by immediate family members. So the important thing about organ donation to know for nurses is that the physician should be notified immediately when organ donation is intended because some tissues must be used within hours after death. So in some cases, the patient needs to be still on life support, knowing that their organs are going to be donated, but they need to be kept on life support, keep the blood flowing through the organs so that they don't die and they can be passed on and help someone else. So the Omnibus Budget Reconciliation Act, or OBRA, in 1990, and this is on page 325, requires all institutions that participate with Medicare provide all patients the right to refuse treatment. So a patient can refuse treatment. They can have an advance directive. And advance directives are written statements of a person's wishes regarding medical care. The first advance directive document developed in 1974 was called the Living Will. Now there's also something called the medical power of attorney. And that's where you select someone to make healthcare decisions if you're unable to. So it's an important thing to state who you want as a medical power of attorney that has your best interest in mind. There's another thing called the 5 wishes, and I think it's on the next page here. Yes, it's also on your next page. So 5 wishes. You can get this online and print it out. I think there's a fee for it. But what happens is the patient can put this in the chart, and it talks about the person I want to make decisions for me when I can't, and it will state that. The kind of medical treatment I want or don't want. How comfortable do I want to be? These are statements from the patient. How I want people to treat me during the time that I'm dying. What I want my loved ones to know. Maybe there's some things they want to say. Maybe they want candles burning, and maybe they want the aromatherapy in the room. It just depends. This is their wish And this is where they can state their wishes, what they want. So it's a really important document. It's not a legal document. It's not like the living will or the medical power of attorney, but it is still stating what the patient wants. It's just not legally binding. There's something called the Harvard criteria that we used for death. It started in 1968, and it's listed on page 327. And that was, how do you determine when someone is dead? So the Harvard criteria. So unresponsiveness to external stimuli, complete lack of spontaneous movement and breathing, a total lack of responses like your PERLA, a flat EEG for 24 hours, lack of circulation to the brain for 24 hours. So if you found someone and they hadn't had perfusion for 24 hours. The first three are enough for pronouncement of death, but it must be made by a physician. So a nurse cannot state that a patient has died. It has to be a physician. So I was at a facility one time, long-term care facility with students, and one of the nurses was making their rounds around 10 o'clock, and when they walked in, they found the patient unresponsive and did not have a pulse. Well, she was a DNR, so do not resuscitate, so didn't start CPR, but still had to call 911 because the patient had to be declared dead by a physician. So when 911 came, they hooked the patient up to a monitor, sure enough, flatline. They called a physician on the phone, and based on the observations of the 911 responders and the EKG, determined that the patient had passed away. So they did have the physician's documentation. So now let's talk a little bit about the dying process itself. So here I want to talk, I have a book from actually Hospice Care, and I like to look at the dying process this way. So the actual dying process often begins within 2 weeks prior to death. There is a shift that occurs within a person that takes them from a mental processing of death to a true comprehension and belief in their own mortality. So they begin to withdraw. Now this is from the book, my book from Hospice. So this is not in your book, but I wanted to share it with you because it makes it seem a little bit clearer to me, I think, because it's actually the person is going from one stage to another. So they begin to withdraw, and they withdraw into themselves. And they usually keep their eyes closed and sleep a lot, stay in bed. They begin to stop eating. Then maybe 1 or 2 weeks prior to death, they get disoriented, but they sleep most of the time. Then maybe 1 or 2 days prior to death, they have a surge of energy. And maybe some of you have experienced that with a loved one. I actually experienced that with my mom. She had this surge of energy where she suddenly was able to walk without a cane. And she was very communicative, and she went to have breakfast with all of her friends, and we stopped and looked at the birds, and we sat out on the porch and talked about ducks and things, right? She was very talkative. And then within 2 weeks, she passed away. So she had that sudden burst of energy. But I think the point that I'm trying to make here is they begin to withdraw. So the physical signs that you see are their muscular system weakens. Now, if you want to know where I am after that long discussion, page 325 starts with physical changes. So the muscular system weakens gradually. Speech becomes difficult. Swallowing is difficult. The GI system slows down. Peristalsis slows down. Pulse slows. Blood pressure drops. Even their temperature drops. They're cooler to the touch. Their respirations, noisy, wet sounding. And this is talked about in the bottom of page 325, where it says noisy, wet sounding respirations, termed the death rattle, are caused by mouth breathing and accumulation of mucus in the upper airways. Skin cool to touch. Sensory changes include decreased pain and touch perception, blurred vision. They have a decreased sense of taste and smell. So here I have on your slide, respirations cease first and the heart stops within a few minutes. So it's important that you remember that first the respirations stop and then the heart stops within a few minutes. The other thing I didn't mention was hearing. As part of sensory, hearing is commonly believed the last sense to go during the death process. So if you're with a loved one, be sure, or if you're a nurse, talk to your patient. Tell them what you're doing. Talk to them like they were with you. Just speak slowly and clearly so the patient understands. Encourage family members to talk to the patient as well. Tell them they love them, but always think that the patient can hear you. And I've had patients in comas where they had absolutely no response whatsoever, but I still talked to them. I still touched them. I still told them what I was going to do, because it's the last sense to go. It's the first one to come in a baby. Baby can hear. That's the first sense. And it's the last one to go in death. So also remember that the heart stops beating within a few minutes after respiration. So respiration cease first. Now there's some physical changes that occur on page 329 under physical changes after death. Rigor mortis. Now I'm sure you've heard of rigor mortis. It occurs within 2 to 4 hours where the body stiffens. Physical changes make muscles stiffen. Algor mortis, the body temperature cools to room temperature. Now a lot of the shows that you see will talk about time of death. How do they figure that out? Well, they figure it out through the liver, and they figure out what the body temperature is according to the room temperature, and that usually occurs within 24 hours. Liver mortis is the breakdown of red blood cells causing discoloration of the skin, and that occurs 30 minutes to 2 hours. So while we're on this page here, there's also table 19.2, which common documents used in end-of-life care. I know we went through some of these already. It doesn't hurt to go through them again. So advanced directive describes documents that give instructions about future medical care and treatments and who should make the decisions in the event the person is unable to communicate. The DNR, we know that is in the chart. It's always you need to check on your patients if they have a DNR in place. It's a written physician's order instructing healthcare professionals not to attempt CPR. Now remember, here's one thing that I see to happen a lot, and that is a do not resuscitate. That means no CPR. It doesn't mean you can't hang antibiotics. It doesn't mean you can't give them oxygen. So if a patient has pneumonia, they don't have to die of that. They can be treated, even though they're a DNR. If they have a UTI, they can be treated. A DNR just means no compressions or intubation. A living will, lay term used to describe any documents that give instructions about future medical care and treatments, or the wish to be allowed to die without heroic or extraordinary measures. Medical power of attorney, some states use that to describe a document used to list the persons to make healthcare decisions. Okay. And then we read through the physical changes. So now let's talk about nursing care at the end of life. So Kubler-Ross's work provides a framework for anticipating and understanding the experience of the dying and their survivors. So it's important to know that nursing care of patients who are terminally ill or dying, you must address their psychologic and physical needs. So it's very important that you remember that. Respect, dignity, and comfort are important for the patient and the family. So patient problems, goals, and outcome criteria. If the patient or family has dysfunctional grieving, the goal is resolution of grief. You want to help them come to grips with their grief and that the patient is dying. And you have proof there. And if you point that out, it will help the patient's family understand what's happening. Do not be judgmental. Everyone grieves in their own way, and that's the way they have to get through it. Some never get through it. Some need counseling, and that's fine to get counseling. And you can help the patient's family with referring them to a social worker, maybe in the hospital social worker, facility social worker, or maybe they need religious guidance. And that's where we can come and help them. So what are some interventions that we need to do? So interventions, there's no need to perform unnecessary assessments. So if a patient is dying, do we need to take their vital signs every 4 hours? Not really. We don't need to turn and cough and deep breathe every 2 hours. So there's no need to perform unnecessary assessments. Priority interventions for anticipatory grieving and unresolved grieving focus on providing an environment that allows the patient to express feelings, if they're alert enough. Open discussions of feelings helps the patient and family to work toward resolution of grief. So if the patient can talk and the family is at their bedside, it's a great experience for them to talk to each other and encourage that. You want to encourage the family to be in the room all the time. And that's why hospice is so great, because if you've ever been to Alexander Cohen Hospice House, each room is like a bedroom. And the family can stay there. There's a kitchen for the family to cook meals and couch for them to sit on and stay, water to drink. It's not like a hospital setting. It's more like a home setting, but without taking them home. Now you can take a patient home and have them be on hospice. They can be on hospice in a facility, or like a long-term care facility, or they can go to a hospice house if they have room there. And that's great because each room has its own bathroom, its own door to the outside, so the patient can be rolled in their hospital bed outside and get sun on their face, which I think is awesome. So I think that's the best place to be, but there isn't always openings. So we want to provide pain control, and it must be consistent pain control. Don't worry about addiction at this point. Just make the patient comfortable all the time. Don't let that peak and trough of pain medicine wear off. So remember, I'm on page 331 now. So people who are dying deserve and require the same physical care as people who are expected to recover, but intrusive monitoring need not be continued. And that's where I talked about no need to perform unnecessary assessments. So the first thing we need to talk about is discomfort and pain. So pain is best managed by scheduled administration of analgesics rather than waiting for the patient to request them. They can no longer bear the pain. Don't wait for that. Fears about opioid addiction are not relevant at the end of life. The priority is to relieve the pain. Fear and anxiety. So most patients fear dying alone. So if you can be there at their side, or family members be at their side, that's great, because patient fear being alone. Dying people often express fear of dying alone. Now I'm on page 332. Explain to them that touching and speaking to the patient can be comforting. If no one else is present, consider having a staff member sit with the patient to provide comfort. Disrupted skin integrity. So it can be a challenge to maintain skin integrity in the final days of life. The patient will be incontinent, so we need to keep them dry. Nausea could be something that they experience, so we want to administer antiemetics as needed. Do not encourage the patient to eat or drink, especially if it makes them nauseated. It's normal for dying patients to gradually stop eating and drinking. Inadequate oxygenation. Secretions accumulate in the airway and patients may be unable to clear them, so you might need to use suction. In the final hours of life, breathing slows down and becomes irregular, and that's called Cheyne-Stokes respirations, and those are characterized by alternating periods of apnea and deep, rapid breathing. So we don't do any intervention at that time. If they need oxygen, we can put oxygen on them. Confusion. As cerebral circulation falls, cognitive processes are affected. Patients' verbalizations may not make sense. They may have hallucinations. It's not uncommon for patients to think they see someone they know, like maybe their mother or their father or their sister has passed away before them. So offer soothing comments and gently stroke the patient. Reorient as appropriate. So what do we do after the patient has expired? So care of the body after death. So there's certain rules. If you look at table 19.4, so autopsy is the first topic. So there's requirements for autopsy. If a person expires by suicide, by homicide, or within 24 hours of admission to a healthcare facility, or from unknown causes, there needs to be an autopsy. And that's usually required by the state. Also, if you look on table 19.4, positioning of the body. So place the body in supine position with arms at their sides. Some religions don't want you to cross their arms, so just put them gently at their sides. Place a small pillow under the head and shoulders and close their eyelids gently. And if you elevate their head a little bit, their eyes will close. Close the mouth. Place a rolled towel under the chin if that's needed. You can put their dentures in place. If they fit in, if they go in easily, you can put their dentures in so that their face looks fuller and not as drawn. That's good. Insert dentures gently. Be sure that you keep the patient clean. Wash soiled areas of the body. Put on a clean gown. Comb their hair. Apply clean top linens and cover the body to the shoulder level. Secure their jewelry, otherwise send it home with the family. And document the disposition of the possessions. So that's in your book, table 19.4, and now I'm going to go to the slide here. So preparation of the body for transfer to the morgue or funeral home. So sometimes that takes tagging of the toe and wrapping the body in a shroud. And some facilities have tables that you can put the body inside the table, and then they just put a sheet over the top, and it doesn't even look like anyone's in there. Because if you have to roll this body through the hallway, you don't want everybody to see that it's an expired body. Also, each state has laws regarding autopsy, required if suicide or death within 24 hours of admission. Be sure that you maintain dignity and privacy for the deceased and family. Preparation of the body for viewing, make them supine, insert their dentures, make sure they're clean. Now there's certain legal and religious issues. So let's go to the cultural considerations box on page 333. And it talks about in Greece, the body is washed by a relative or older woman. Roman Catholics, the body should be shrouded until sacraments have been performed. So the priest needs to come in and perform sacraments if he hadn't already done that prior to death. And the Orthodox Jews, so I used to work in a Jewish hospital down at Cedars-Sinai in Los Angeles, and the cultural rules that they have concerning death are very clear, and you have to follow them. So a dying person is never left alone. The body is not left alone between death and burial, which must occur within 24 hours. So they do not embalm their loved one. So they have to be buried within 24 hours. Body must not be touched for up to 30 minutes after death, and it has to be touched by a man. So women aren't allowed to touch Jewish body. It can be the rabbi. So because they have to be buried so quickly, funeral arrangements have to be made rapidly. Let's see if there's anything else here I want to talk about. In some of the other religions, maybe the body has to face Mecca at the time of death, so that needs to be respected. So be sure that you know the cultural considerations of the families and the family's wishes. That's very important. So what about us? What about the nurses? We have needs because we've just experienced one of our patients that we maybe have taken care of for months or years sometimes. They're dying or they have died. So nurses experience feelings of helplessness, sorrow, guilt, and frustration that they can't help the patient. And nurses who are in touch with their own feelings are better able to help patients and families deal with their feelings. So we have to know how we feel about death. We have to be comfortable with death in order to help our patients with death. That's why there's some nurses that are really good with hospice. Some patients, that's not their thing. You need to work in a different area. And remember, grieving is a normal response. And nurses need to be supportive of each other. and prevent burnout and loss of sensitivity to patient needs. Because sometimes you just get numb or you go into denial, because we suffer from some of those stages of grieving also. So be aware of how you feel and how your other friends are feeling, because really we can only talk to each other about it. It's hard to talk to the family about how we feel because we have to be concerned about how they feel. So we talk to each other, and that's how we help each other. All right, thank you.